Good afternoon, doctors. Again, my name is Angelo Mendoza. I'm from the Philippines, from the University of Santo Tomas Hospital. I will be presenting my paper entitled Comparison between Posterior Hamstring Harvest versus Anterior Hamstring Harvest, a meta-analysis. Sports injuries requiring reconstructions are one of the most common orthopedic procedures. This include ACL, MPFL, and PCL reconstructions. There are many options for grafts. Most common grafts are harvested from the hamstring, patellar tendon, quadriceps tendon, as well as several types of allografts. Hamstring tendon autografts is the most used in the general population due to less anterior knee pain and better extension. There are various harvest incisions, the vertical, horizontal, and oblique, and localization, anterior and posterior techniques to harvest the hamstrings. Historically, the anterior approach has been the most commonly used to harvest the hamstring due to the coincidence that the harvest site, and the tibial tunnel location are in the same area, limiting the size and number of incisions needed. But it comes with disadvantages: difficulty in identifying the tendons, iatrogenic saphenous nerve injury, graft site morbidity, anterior scar-cosmesis, and premature graft amputation of the tendon during the harvest. To hopefully resolve the aforementioned challenges, the posteromedial approach for hamstring harvest was first developed by Prodromos in 1991. Studies have shown that the posterior approach to result in superior outcomes in saphenous nerve injury, post-operative sensory alterations, time to harvest, and cosmesis. Currently, there has been no systematic review or meta-analysis comparing the two approaches. The aim of this study is to objectively compare the outcomes and complications of these harvesting approaches. This is the research question of my study. The population are patients of all ages that underwent hamstring harvest either through anterior or posterior approaches, with the intervention of a posterior approach in the comparator group of the anterior approach group. The primary outcomes was operative time, nerve injury, and graft length. A comprehensive electronic literature search was conducted and yielded 1 RCT and 4 cohort studies that were reviewed and included in the study. These are the studies and their characteristics. Overall, there were 425 patients that were enrolled in this study. After article review and data extraction, statistical analysis were conducted using RevMath. Pooled risk ratio and standard mean differences was utilized as the summary effect measure for categorical outcomes. Statistical heterogeneity between studies were scrutinized using chi-squared test, I-squared statistics, and tau-squared statistics. The most important finding of this study was that the posterior approach had consistently shorter grafts compared to the anterior approach. Although only 2 studies reported graft length, they showed consistent results of graft size difference of about 16 to 18 millimeters between groups. In favor of the anterior group, the posterior approach averaged around 270 millimeters of semitendinosus graft size, consistent with one study with 175 patients. The average semitendinosus graft size in this study were 286 to 290 millimeter for the anterior group, which was also consistent with a study by Goyal et al., which studied the anthropometric data of patients correlating it to graft size. The difference of graft size between groups can be caused by the fascial attachment in the insertion site of the hamstrings, which is released in the anterior approach. This fascial attachment was found to be around 2.6 centimeters. All included studies observed for incidence of nerve injury post-operatively, although 2 studies did not find any case for either group. The other study had a total of 18 incidents of nerve injury among 405 patients, and the forest plot shows that the posterior approach has less risk of nerve injury. In addition, there was no heterogeneity detected among the studies. 3 of the studies recorded total operative time. All of the included studies showed that the posterior approach was faster compared with the anterior approach. The difference was found to be statistically significant, but the detected heterogeneity was high. This could be caused by the different expertise of the surgeon that performed the cases. For secondary outcomes, infection, incision length, and range of motion were analyzed, and all showed no significant difference between groups with high heterogeneity in the incision length and range of motion results. In conclusion, our study showed that the posterior approach to hamstring harvest also has a disadvantage that has not been widely recognized. It offers better cosmesis, theoretically faster and easier procedure, and less nerve injury. The posterior approach produces a shorter graft due to the insertion anatomy of the hamstrings. But this approach requires a reverse reamer. Further studies are needed to confirm these findings. With the findings of this study, posterior approach can be recommended, but knowledge of its advantages and disadvantages is essential for proper patient selection. These are my references. Thank you.
Thank you,